Recording is
So I am really privileged to welcome Dr. Catherine Standish, who's going to be presenting today. She's one of the authors of the 2023 update to the Academy of Breastfeeding Medicine Clinical Protocol number 21, breastfeeding in the setting of substance use and substance use disorder. And she's here to talk a little bit about the overview of those guidelines and drum up maybe some discussion also for this lovely group. Her bio is in the chat if you'd like to learn more about her. Please feel free to put questions in the chat during her presentation, and we will definitely have time for Q&A at the end. And I'm just going to let Catherine let you take over.
Awesome. Hi, everybody. It's so great to be here. Let me share my slides here. 1 second. Okay. Let's see. All right. Are you seeing just my slide?
Yep,
okay.
You're good.
Great. Awesome. All right. So I'm going to talk about breastfeeding in the setting of substance use and substance use disorders, with a particular emphasis on talking about the Academy of Breastfeeding Medicine protocol. I have to preface this with the fact that, well, I am listed as an author on this protocol. It's really the other 5 people listed here that did a lot of this work and really put it together. They brought me in at the last minute, I would say, because I brought up a few things to add and they were excited about that, so I joined. But it is an area that I do a lot of work in, and I love talking about this topic and having conversations and meeting different providers who come to this topic from a different perspective. I talk a lot to lactation consultants and perinatal providers and pediatrics and family medicine and OB and such. And I'm really excited to be here with you talking with folks who have who specialize in addiction, and particularly women in addiction. Your group is well known, and it's great to be here with you today. Oops, I didn't start on the first slide though, did I? Whoops. There we go. Okay. So I like to preface all my talks, whatever they're about, and if they touch on breastfeeding, with the fact that we all come to this topic often more with personal experiences and stories and knowledge than even professional medical health related stories and understanding. And that those, regardless of our background with human lactation, our personal stories are the most important ones. And we have a lot of different experiences, I'm sure, within this group as well. And my work focuses on helping people meet their infant feeding goals, whatever those are. And we all face in the United States a lot of systemic barriers in parenting, in many facets of parenting. And the further I dig into the field of breastfeeding and the medicine, the more I realize that really most of the challenges around infant feeding come from sort of systems level issues. And I'm going to talk about a few of them here. So the protocol that we're talking about is developed by the Academy of Breastfeeding Medicine. And actually soon after this protocol was published, I was asked to serve as chair of the protocol committee of the Academy of Breastfeeding Medicine for the last 3 years. I've been leading up efforts on that committee. The Academy itself was founded now really almost 30 years ago to bring together physicians who had a special interest or training or practice around the area of breastfeeding. And the mission of the organization is to educate and empower health professionals to support and manage breastfeeding, lactation, and human milk feeding with the purpose of supporting improved health outcomes. So just a little bit more about breastfeeding medicine, because I actually think I think about addiction a lot when I think about the development of this sort of subspecialty. So I don't know about where all of you studied, but at my medical school, they taught nothing about lactation, The only time I remember it mentioned was when they, kind of mentioned oxytocin and its impact in the body and its functions. So most of us really didn't get taught about this organ system, but it's actually a really unique and complex one. The kind of number one highlight of why it's complex is that it's a two-person organ system, right? So just like sit with that for a second. Like that's pretty like, wow. The infant drives milk production in a lot of ways, right? So there's so much give and take there between the parent and the infant. It is an organ system that doesn't get fully developed until pregnancy and sort of recesses and comes back with each pregnancy. So there's a lot of complexities there. And we have a lot of challenges in our health system because we are not educated in health as health providers. There's a limited evidence base in terms of sort of clinical breastfeeding medicine. And we've had a loss of cultural knowledge. So sort of a recent history, we started using formula in this country over 100 years ago, and that was before we had the first randomized control trial some 50 years later. So the use of formula is sort of this sort of widespread, uncontrolled experiment across the world in terms of what that might do to human development and health. And it was not until the 50s that there was sort of starting to be a pushback against this idea that formula was actually better for health, with the Leche League and other groups coming up and trying to support breastfeeding again in the United States. IBCLCs, lactation consultants, actually came out of La Leche League group, local community group leaders, which is a really interesting kind of relationship between communities, parents, families, and the healthcare system. And then the Academy of Breastfeeding Medicine was founded in 1995. We have midwifery groups focused on lactation as well, and of course, midwives have been doing this work for millennia and generations. And in 2014, the University of Rochester founded the first fellowship in breastfeeding medicine, and they're still the only division of breastfeeding medicine and fellowship in the world. I completed that fellowship a couple of years ago, and we now also have the North American Board of Breastfeeding and Lactation Medicine with a subspecialty licensing exam that's been in place for the last year and a half. So it is growing, but has long been sort of left out of medicine. And for many decades now, lactation consultants within hospital systems have been sort of the experts in breastfeeding. Lactation, the IBCLC does not require a kind of a healthcare background. A lot of folks are RNs, but that's a very different scope of practice than a physician or a prescribing provider, APP. So breastfeeding medicine comes in to kind of fill that gap where there's need for knowledge of sort of complex medical issues that may interplay with breastfeeding, recommendations around medications and how to make decisions around that, that would be sort of outside of the purview of an RN or an IBCLC. So getting into the topic at hand, I think I can skim over these couple of slides because it's all known to this group. But we, of course, have a relatively high prevalence of opioid use disorder in pregnancy, which I'm going to focus a little bit more on in this talk. And as well, of course, neonatal opioid withdrawal, as well as withdrawal syndromes to other substances, both prescribed and non-prescribed in the United States. These levels seem to have kind of leveled off a little bit in recent years, but I think we're also waiting for updated data. If anyone out there has any new publications, send them my way. Every few months I do a search, but it seems like we're a little bit out of date at this point. So breastfeeding is now widely recommended for parents with opioid use disorder and with substance use disorders in recovery, and infants with withdrawal and NOWs in particular, neonatal opioid withdrawal. This is because there are really real benefits to these infants that are specific to infants with opioid exposure. And I'm going to get into how there are also some benefits specific to parents with opioid addiction. So breastfed infants who so infants with NOWS who are breastfed and receive mother's milk have much shorter hospital stays. They have reduced need for medication for NOWS, which kind of goes hand in hand, and really just reduced symptoms. And then also kind of more relevant to this population, although not specific to them, is that, infants that have opioid exposure are more likely to be acutely ill in some way, born premature, small for gestational age, require a NICU stay, have other medical issues that put them at risk of morbidity, mortality specifically. Breastfeeding reduces the risk of postperinatal death. It reduces the rate of SIDS, which infants with opioid exposure have have the highest risk of SIDS of any sort of exposure that we know of. And of course, breastfeeding reduces the risk of adverse neurodevelopment that these infants are also at risk of. So really real concrete benefits that I think are a lot clearer than in sort of the general population in a high-income country like the US in terms of breastfeeding outcomes. For mothers, there are, of course, sort of the general the benefits to breastfeeding that exist, in all people, but specifically that, I think is important to think about for people with histories of addiction is that with breastfeeding, we do have a different form of attachment. It's not the only way to achieve attachment, of course, but it is different. We can see in the research, like in functional MRI type studies, et cetera, improved responses to infant cues and parenting efficacy. And for a population that may really have decreased parenting efficacy, really be stigmatized around their parenting, have difficulty with infant cues, having this benefit of breastfeeding is particularly important. So again, something that perhaps in someone without addiction, breastfeeding may not be the only factor that's important. We might see real improvements in folks with addiction. We also see lower risks of postpartum depression and anxiety in people who breastfeed, and then the lower lifetime risks of other morbidities, particularly cardiovascular diseases and breast and ovarian cancers. And that increases with the length of time of breastfeeding. So the longer one breastfeeds or the more children one breastfeeds, the more the health benefits to the parent. I'm going to skip over that a little bit for the sake of time. We kind of talked about these things. I also really wonder and want to see more research on if breastfeeding might actually improve recovery for people with addiction. So we know that pregnancy is a period of increased engagement in substance use disorder care. And with breastfeeding, you have an extension of that period in which really the parents' body and their physiology and their health status directly impact the infant. Of course, the parent's health is always important for an infant, right? That caretaker always, that they're number one. But in terms of that direct impact of what medications I'm taking, how am I taking care of myself, et cetera, that is extended when we have lactation in the postpartum period. And some of my research, I'm starting to try to chip away at that a little bit, and I hope that we can all learn more about this in the future. And of course, particularly important when we look at overdose rates and even overdose death rates in the postpartum period, which increases during that phase of a woman's life. So taking a second here to think about what we've just discussed, the United Nations considers breastfeeding a human right, right? It's part of the physiology of a woman's body. It is part of the needs of a newborn human infant. And it has a profound impact on sort of lifelong health outcomes. And for that reason, when we have systems and structures in place that really pose great barriers to breastfeeding or inhibit one's desire to breastfeed, or just the natural sort of what is happening in the perinatal time, it is something that we should take quite seriously. And people are. So over the last decade or two, we have seen great increases in the number of dyads where there is prenatal opioid use increasing their rates of breastfeeding. This is data that Dr. Schiff, who probably a lot of you know, published from our hospital, from Boston Medical Center, as we were, well, as they, because I was only barely entering residency at the end of this chart, that they were monitoring as they implemented changes in policies and recommendations around breastfeeding, education of staff and patients. And they saw a great increase in the number of people with opioid use disorder that were cared for at our hospital initiating breastfeeding. But the purple line is those who are breastfeeding at hospital discharge. So even there, within a week, you see a drop off of, almost 20% that remain the same. So we had increases, but we have fast drop off in breastfeeding. We also see reduced duration of breastfeeding at the population level. This is CDC national PRAMS data looking at anyone who reported any opioid use, even prescribed or even very short term during pregnancy, and then of course also includes people with use disorders. When we look at this, we see a much decreased odds of breastfeeding at 6, 10, or 20 weeks compared to pregnant people that did not have any opioid exposure during pregnancy. So there's really something going on here. And this is just a small study that's demonstrative of probably what a lot of us see in our practices, which is this steep drop off, even when of breastfeeding in the postpartum period. So even when we have relatively high rates of initiation, in this study, it was 80%. And I believe for the study, that was of people who were considered eligible. I was recommended by their providers to breastfeed based on their recent use history. And then a quick drop off even by the first month. And this really reflects the many barriers that patients experience. So our protocol starts to try to get at that and help healthcare providers and parents really in making decisions and informed decisions around breastfeeding and the setting of substance use and use disorders. With this protocol, the last one had been published, I think, in 2015. So with this update, I think there's really important shifts that reflect the shifts that we've all had throughout sort of the healthcare system in really using patient-first language and patient-centered approaches, really taking patient autonomy into account. In the perinatal space with breastfeeding, there's often a lot of kind of almost conflict in a way between sort of the care of the infant and the care of the parent and how we think about that. As a family medicine doctor, I take care of both parents and infants, adults and their children. And I find that I can bring those two things together a lot more easily, but we do have separate specialties. And I think it is important to consider to continue to look at people, these mothers and infants as dyads, right? Even when there are structures in place that may be separating them, whether it is hospital, NICU procedures or child welfare procedures, et cetera. They essentially at their core were a dyad. And what does that mean for the two of them going forward? So in this case, our guideline really is aiming to support clinicians to work in partnership with individuals who use non-prescribed substances or with use disorders around making these decisions. We talk in the protocol around about kind of policies that can be implemented and support structures that can be implemented in hospitals. And actually this slide, I'm going to skip over real quick and get to the next one, which is our first set of recommendations in the protocol around supporting breastfeeding. So these include essentially that those who engage with substance use disorders who engage in multidisciplinary prenatal and postpartum substance care we see better outcomes, right? And better support for breastfeeding and postpartum care. And this is strongly recommended. And coming from an academic center, it seems normal, but in a lot of parts of the United States, this type of care isn't available. Individuals who discontinue non-prescribed substances by delivery hospitalization should be supported in breastfeeding. And we can get into details on that, because that's probably the sort of top thing that people go to this protocol to learn about. We talk about the need for targeted perinatal didactic lactation support, prenatal education, inpatient postpartum care, ongoing care postpartum. And I'll just add that peer support can be very, very important in this and lactation support that is integrated as much as possible into perinatal addiction care. And I see Lauren Narby there in the in the audience. I'm not going to present about our study, but we did a survey that we're about to publish of perinatal programs, and I think growing numbers are involving lactation consultants and certified lactation counselors and peer specialists who have training in lactation care in their programs and supporting dyads, which is fantastic. And then finally, establishing breastfeeding guidelines. So having policies within your department, within your hospital around how to manage toxicology testing, how to manage recommendations around breastfeeding, timing of breastfeeding. And this is so important to mitigate bias in those recommendations and testing, and to facilitate consistency across the research, well, across breastfeeding, and specifically amongst people who have substance use disorders. We see time and again that people are experiencing inconsistent recommendations. One provider says one thing, another provider says another, and this further causes mistrust in the healthcare system. So operationalizing our protocol. So this includes consistent policies, as I mentioned, using evidence-based and individualized toxicology testing and other clinical information to make decisions and provide recommendations around breastfeeding, and doing staff training and education. So the use and limitations of toxicology testing. So I'll just read straight from our protocol here. So all urine drug testing must be interpreted within the clinical context, including patient history and collaborative information that should be used to guide the need for any further confirmatory testing. So I can't emphasize this enough. I don't think that we can go into any medical decision and base it 100% on a lab test. We have to take the person, the dyad, into account, the clinical situation, the socials that you know, discussions with the patient, right? There's going to be more information that you use to make a recommendation, to have a conversation with a patient, than simply one test or a series of tests. That is a piece of information. And I think that's something that also can get misinterpreted about the recommendations in this guideline. The recommendations can't be boiled down to, the date at which a toxicology test was taken, or the timing in terms of, the end of pregnancy or delivery. That needs to be taken into account with other information as well. And then we go on to talk about, birthing individuals motivated to breastfeed who report recent non-prescribed substance use and/or have positive toxicology testing at the time of delivery should be supported in pumping to establish a milk supply. The decision of whether to give the pump milk to the infant and when to start breastfeeding should be made using a multidisciplinary approach involving the patient and clinician of both the parent-infant dyad, right? So this is a multidisciplinary team-based type of discussion. And these are complex. They do look a little different in different settings and for different patients. And we continue to be challenged with, new situations at our hospital. And I hear from colleagues elsewhere similarly. I think as we do more and more research about how different substances and drugs get into the breast milk, we'll also be able to make better recommendations here. So toxicology testing, I think this crowd doesn't need this slide, but obviously it's limited. And I'll just highlight also that in the perinatal period, we know that fentanyl specifically seems to have this sort of delayed clearance, right? And that can be very confusing for our colleagues. And, as addiction specialists, as breastfeeding medicine specialists, I think that we are folks that can our colleagues can turn to ask about these complicated clinical scenarios and what do you do about a fentanyl or norfentanyl result that continues to be positive days or weeks later, right? This seems to be particularly heightened in the perinatal period and can make the interpretation of testing complicated, especially when you're focusing only on a lab test and maybe there isn't, a consistent provider, consistent communication, a good trusting relationship with the parent, with a patient, right? That makes it hard to then interpret a lab test in the context of the rest of the clinical scenario and what the patient is reporting. Similarly, THC can persist in the urine for quite a while after chronic use, again, complicating a lot of perinatal decisions. In some places, they're still testing a lot of people for THC in the perinatal period. So the recommendations in the ABM protocol about the timing of toxicology testing are based on this study that Miriam Harris, who couldn't be here today, led up. And it's really the only study the high quality study that we have. This looked at a single site, Boston Medical Center, cohort study, retrospective cohort of 503 women that were receiving MOUD, and found that the time of delivery urine toxicology test had the strongest association with ongoing non-prescribed postpartum use. So really what you're concerned about with a breastfeeding decision is there a high risk of ongoing use going forward that would cause exposure to the infant going forward through the breast milk, right? There was use earlier in pregnancy. There was use even during the third trimester. That infant was already exposed during the pregnancy. The question for breastfeeding is there going to continue to be exposure through the breast milk? And when we are looking back as far as 90 to 30 days prior to delivery at toxicology testing, we have really poor positive predictive value of ongoing use. And that improves when we're looking at the testing done at the time of delivery. And so that's why in the IBM protocol, we shifted the recommendation that had previously been 90 to 30 days in the 2015 protocol to be at the time of delivery. And a lot of hospitals have incorporated this in the survey study that Lauren Narby and I did. I mentioned over half of the programs that we surveyed cited that they were using the time of delivery as the main lab figure to inform breastfeeding recommendations. So in the I'm gonna be okay, we're good on time. In the protocol, we then go on to have substance-specific recommendations around breastfeeding. We included both non-prescribed and prescribed substances in some cases, such as benzodiazepines and stimulants where there may be prescribed use. We added new substances that hadn't been in the prior protocol. And we also included treatment, medication treatment for SUDs, because those often also come up in questions of exposure to the infant via breast milk. So these are the recommendations, and they're easily found in the protocol. Of course, we continue not to recommend breastfeeding in the setting of ongoing non-prescribed use for any medication or for any substance or medication. But we also include here certain infant monitoring and maternal monitoring or potential harms to help guide clinicians in thinking about, if we're uncertain about exposure, what might we look for, what might make one concerned, and any additional considerations considerations, for instance, around maintaining lactation and pumping during a time where the milk isn't being given yet. And the use of, for instance, benzodiazepines as a medication for a treatment disorder or other anxiety disorders. In general, when a medication like that is prescribed, we know the dose, we know that doesn't have contaminants, et cetera. We continue to recommend breastfeeding. With medications that have sedative properties like opioids, benzodiazepines, certain some of the antipsychotics, for instance. When it comes to exposure via the breast milk, so I'm talking about prescribed medications, the vast majority of cases of that have been reported of infant effects that are thought to be due to breast milk exposure are in cases of multiple sedating medications being used by the parent. So, when I often get consults about medication exposures and they might be asking about one specific medication. Typically, for instance, for a benzodiazepine, if that's the only sedating medication, there's really no contraindication to breastfeeding. It would only be at a very, very high dose of certain meds that you might be concerned with only one medication on board. But most of the cases that have been reported are multiple meds that are sedating. So that's more where you want to have concern. And when it comes to that sort of situation, one option that we haven't mentioned in this protocol, but I hope that we might in a future protocol, is diluting breast milk. So not giving exclusive breast milk. If it's pumped, it can easily be diluted with formula or breast milk that doesn't have medication in it. So if there's concern about medications, one can continue to pump and potentially dilute that milk, thus, reducing by half or more even, depending on the dilution ratio. We also have recommendations around alcohol, nicotine, cannabis. Alcohol here, we mentioned that it's really in moderate to high consumption that there is concern for breastfeeding. With alcohol, really, as with all use disorders, the concern is, can this person parent the infant well, right? Are they going to be able to be a caretaker if they have active use or are intoxicated? Right? Whether it's a use disorder or not. So with alcohol, really, I think the bigger concern is around intoxication and ability to care for an infant. And that's a problem whether you're breastfeeding or formula feeding. The amount alcohol does not accumulate in the breast milk. As soon as it's left the serum, it's left the breast milk. So, I generally tell people, if you do not, if you have one or two drinks and do not feel tipsy, continue breastfeeding your child as normal, which is a little less conservative than actually what we wrote in the protocol, where we say to wait a little bit. Because it really doesn't accumulate, and it's low risk, especially for very infrequent exposures. Nicotine, we continue to recommend breastfeeding even during tobacco use, right? So that infant will potentially have second and third hand exposure regardless of how they're fed. Some nicotine does go into the breast milk, but the thought is that the benefits of breastfeeding, particularly to reduce respiratory diseases, asthma, et cetera, that might be worsened by second and third hand smoke exposure, are improved by breastfeeding. So a lot of parents are worried about this, have questions or confusion about it, and this can be an area that you can reassure folks. And for folks with other use disorders where we see really high rates as well of tobacco use, this is yet another barrier that we often come across where, well, they told me that I can breastfeed with methadone, but I also smoke, right? And that was the reason that someone didn't breastfeed. So this is going to be a really important area of education for both providers and patients. Cannabis is a perennial challenge. Here, of course, we recommend cessation or reduction of cannabis, and I I mean, I always take a harm reduction approach for all substances, but particularly around cannabis. I'll see patients sometimes who, have reduced as much as they can, but continue to have some use. And then it's an informed decision talking about risks and benefits, in a non-stigmatizing and blaming way, right? I think there's a lot of research out there that we can cite that will make parents feel that they are harming their child when we just don't know, at what level of use, et cetera. I think it's challenging. And again, what is that risk benefit between the benefits of breastfeeding and the risk of exposure? We don't have great research to guide us in that. We recommend reduction as much as possible during breastfeeding. SUD treatment recommendations, pretty much all treatment is safe, especially commonly used things. And then just a couple last words on operationalizing some of the ABM protocol. Eat, Sleep, Console for neonatal opioid withdrawal syndrome is, highly evidence-based, really works well in the settings where it's been implemented and is highly supportive of breastfeeding. One of the tenets of Eat, Sleep, Console is a lot of skin to skin and time with a parent, which of course has this interplay with breastfeeding where it both supports breastfeeding, but also mimics really a lot of the benefits of it. So even if one is formula feeding, doing a lot of skin to skin is really helpful for the stability of the infant. And that's one of the tenets of Eat, Sleep, Console. And indeed, we see better breastfeeding out. Sorry, there's a fly bugging me here. We see better breastfeeding outcomes in infants that were in dyads that were managed in the hospital with the Eat, Sleep, Console method. We also recommend baby-friendly hospital practices. So this is the WHO's program to help hospitals implement evidence-based breastfeeding support. This is that same PRAM study that looked at breastfeeding among people with any opioid use in pregnancy and found reduced receipt of the baby-friendly 10 steps in patients that had any opioid use. So this may relate to the hospitals that they delivered at that perhaps were not baby-friendly. These are evidence-based practices that should be implemented in all hospitals, but baby-friendly hospitals sort of are held to the standard of actually doing them. But also because we even know in baby-friendly hospitals, we see disparities in the receipt of the baby-friendly practices by social demographics, income, race, ethnicity, et cetera. And so I think that patients with use disorders are often not getting baby-friendly breastfeeding support the way that other patients are. That includes things like breastfeeding in the first hour, skin to skin in the first hour, and focusing on on-demand feeding. And then there's also a need for sort of specialized care for the dyad who is breastfeeding and has an infant with withdrawal. Just the symptoms of withdrawal in the infant really make feeding problematic. This is why Eat, Sleep, Console, it starts out with eat, because it's not always so easy. So they may have a poor latch due to poor regulation or impaired neurodevelopment. They have high metabolic demand and so high, more drastic weight loss, which leads to supplementation, often with formula, or that the amount of breast milk provided isn't sufficient, needing supplementation. They have poor state control and are not feeding on demand. And then they may have other morbidities that make breastfeeding challenging, as well as separation, which happens in many settings where the infant has a prolonged hospitalization after the parent is discharged. Skip over that, just about addressing them. And then finally, maternal comorbidities that impact breastfeeding that may be more common amongst people with substance use disorders. Of course, high rates of co-occurring psychiatric and mood disorders. And I mention here Abilify because it actually really impacts milk production. So it's not the ideal medication. Other SSRIs are very are well studied in lactation and safe, and as are other medications for mood disorders. But I just put a little caution around Abilify. Tobacco use is associated with low milk production, so not just concerns around do I breastfeed or not, but there's either uncertain if it's actually a physiologic issue in terms of tobacco use, or if it's more a social issue. But we see lower production. Pain for people with opioid use disorders in particular is challenging in the perinatal period. So having plans in place to address breastfeeding pain, to reassure patients, to prevent it, because this can actually be a barrier. People choose not to breastfeed because they are worried about pain and how that will be controlled. Social support may be different or lacking. Folks might not have family or partners that are there to support them in infant care. And residential programs can be supportive or less supportive, right? Even in ways that are hard to identify, such as having groups that one must attend and feeling uncomfortable breastfeeding your baby while other people are bottle feeding their infant in those groups, things of that nature, where I think structurally we can help put into place practices that help parents that are trying to breastfeed in those settings. And then thinking about relapse during lactation. And this is where I think the folks in this group can really have a big impact, because these are hard conversations to have, right? I think it takes a good relationship and a lot of trust with a patient to talk about even the possibility of relapse, right? A lot of maybe pediatricians, the infant providers might not feel comfortable having that conversation with the parent. But this happens, and parents don't know what to do because no one's ever spoken with them about it. The University of Rochester has a nice format for actually an infant feeding relapse plan. So, talking ahead of time about what would you do if this happened? So what do you need to have available at home? Do you have pumped milk available that can be fed to the baby? Do you have formula available? Do you know how to mix the formula? Do you have bottles if you're only directly breastfeeding, right? I mean, it seems silly, but these are the kinds of things to think about. Where's a safe place that you're going to put the infant if you can't hold them or take care of them in that moment? Who are you going to call for help, a support, another caretaker, family, friends, the infant's provider, the mother's provider? Who are the people that need to be informed, and what to do from there? I spoke with someone who stopped breastfeeding for 3 weeks after one instance of use, which is absolutely not necessary, but they didn't know what to do. They had no one to talk to. And it really impacted their ability to continue breastfeeding because they had significantly reduced production after that because of not breastfeeding for so long afterward. It's a hard moment, no matter what, and this complicates it further. So having those discussions is I think really helpful. And that's all I have. In the coming probably month or two, we're going to put out a handout for this protocol. It's been delayed for a lot of reasons, but we have handouts on our ABM website for our protocols as we publish them. Not all of them going backwards, but this one for SUD will be coming out soon. And I can share the links for some of these other resources. That's all I have.
Thank you so much, Dr. Standish. This was wonderful. We've had a lot of questions in the chat. So I'm just going to jump right in with a couple, just if that's okay. So one of the questions that we had was about your second recommendation about the timing of the timing, yes. With regards to the urine drug tests, I put the reference to Davita Ship's paper that looked at the urine drug test at the time of delivery, and that was predictive of a positive urine drug test in the postpartum period when there would be breastfeeding, but positive urine drug tests that occurred before the delivery hospitalization were not predictive. So I did add that citation as the evidence that you also cited in your presentation. But if you could talk a little bit more about that, especially in the clinical context of we all have those patients who come in and the delivery hospitalization is their point of contact with engaging in substance use treatment. And their most recent use was very recent, potentially, before that delivery hospitalization. If you could talk a little bit about how you clinically manage those patients in the context of that protocol guideline, that would be helpful.
Yeah. So We didn't include in the guideline specifics around when to initiate breastfeeding, how to make that decision in terms of the timing, because we don't have great research yet. Some of us are working on trying to make that happen. And maybe in the next iteration, we'll be able to have better evidence to cite and give more recommendations around that. But I can speak anecdotally in terms of what we do and what some other centers do. In a lot of places, we recommend holding off on providing the infant breast milk for about 72 hours and redoing testing at that time. Whether one uses a quantitative test or not at that time is sort of a piece of is different in different centers, as that can, continue to be sort of positive at a low level, or might add additional information. One also has to take into account if that patient was given fentanyl during labor or during a cesarean section, which often happens. So you want to look at that, because that would potentially prolong positive tests. I have not seen, like, personally, I don't think that we should be following the norfentanyl or metabolites for fentanyl, for example. It's inactive. I don't know of any evidence that it can become active for infants. But if the fentanyl is low or undetectable, then I would take that as an indication that it's not getting into the breast milk and we don't need to be concerned. But I think all of this needs more research. If this is certainly a common scenario where the presentation to labor and delivery is the first presentation, right? People are really scared to get prenatal care when they're actively using, because of histories of criminalization and concerns about their child being taken from them, trauma around that in the past, so many issues. If someone is really desiring to breastfeed and dedicated to that, especially while this infant is still in the hospital, that is a great time to try to support that parent in doing that. If, this might be helpful for they're beginning to engage in treatment and recovery and care for themselves, right? And it can be done in a safe and controlled way, following testing, monitoring the infant for any potential effects. It's, there's a lot that we have to trust in parents all the time. Whenever any infant goes home from the hospital, we have to trust that they're going to buckle them into the car seat correctly as they leave the hospital. Even for, people who are PhDs, car seats are hard the first time you use them. Like there's so many things like that. We have to trust that they're not going to leave their 3-year-olds in the care of an uncle who's going to abuse them, right? Like we constantly have to assume the best of people and know that infants are going out into the world, right? And so this is an extension of that is much more kind of, I think we feel it more strongly, and we feel it very strongly when patients are in our care. But we do have to have some amount of trust and that kind of positive regard for families and patients. And these are the hardest things in medicine, I think.
I love you putting that into context, right? Within general medical care, when we're thinking about the early, the infant care, and also this pregnancy to postpartum transition for the birthing parent. I just want to emphasize that you kind of mentioned the 72-hour thing. Some Bonnie Rudolph also put in the chat. That's kind of what they do at Swedish. So, but I just want to emphasize and speak. Tell me if I'm saying this wrong, but you mentioned earlier one of the other recommendations was to support parents if there is a delay in being able to provide breast milk in initiating, correct, the breastfeeding process, the breast milk process. So just
Yeah, and so
that's an opportunity for the patients.
Exactly, really important to have lactation consultants, consulted and supporting the parent early skin to skin, if possible. Hand expression of colostrum is very, very small quantities in the first day or two, and then transitioning to electric pumping, and it has to be frequent. It's a lot, and that is one of the complexities of this. Even when the breast milk is being given, very often patients find themselves needing to pump because the infant might have a difficult latch or have a need for a higher amount of milk than they're making. And pumping can be uncomfortable after cesarean. It can be very uncomfortable. You continue to have contraction pain, et cetera. So that isn't as simple as it might sound, even just the pumping.
I love those practical tips. Those are ways that I think a lot of us can take even today to help advocate for our patients who would like to provide that breast milk to their infants. Another question that came up in the chat during your presentation was about when getting down to stimulants. And so in talking about the evidence behind the non-prescribed stimulants versus prescribed stimulants, if you could speak a little bit more about kind of that nuance that sometimes comes up in our patients, and how that was handled in the development of the guidelines.
Yeah, and oftentimes we really had to look to prescribed medications to even to make in consideration of their non-prescribed use because we don't have in by nature you can't study the non-prescribed use in the same way. You don't know the dose, right? And so it's really hard to know, like you can't get a relative. What we do in with prescribed medications and lactation is that you look at you take the maternal dose, some other factors like weight, et cetera, and the mother, and then you look at that amount that's in the breast milk, and from that you can calculate a relative infant dose. So what's the percentage that gets it to the infant? And generally for medications, we consider anything less than 10% to be safe. Of course, the exceptions of things that are highly dangerous, like a chemotherapeutic or something like that. But in general, under 10% is typically considered a safe level to have exposure to the infant through the breast milk. But we don't have information like that if we don't have a dose, which we don't have typically for unprescribed use. And then there's also the concern of street drugs having contaminants and things that we don't know. So those are sort of the differences between certain prescribed and non-prescribed use is in that uncertainty. But I think in general, for instance, unprescribed use, but of pharmaceuticals, for instance, in the case of like a stimulant, that it might be a prescribed stimulant, but it's used without a prescription. You can feel a little more confident, I would say, taking the patient's report of their use and making decisions based on that, because you have better information and better knowledge about the actual substance that was used. And I see somebody had a question about like 30 days. I mean, there's no evidence. And it's part of how I think stigma works into these types of recommendations from like child welfare and even from other medical providers. And to pump and not provide that breast milk for 30 days is incredibly hard. It is a very demanding thing. You have to pump every 3 hours, at least in the beginning, including at nighttime, right? So, and to be separated from your child while you're doing that and to not be able to give the milk is just deflating and really hard to keep up the enthusiasm around that. I mean, I personally, I haven't seen a parent do that for that long.
Yeah, so I love how I love the sharing in the chat and also from you, Kate, too, about little nuggets that we can bring to help advocate for our patients. So when a lot of times we're faced with these challenges with the systems that we work in that like to recommend things that are not based in science or evidence, but are telling our patients to do that. So please, I put the reference to this guideline in the chat a couple times, and I do want to say that, reading through it the first time, it was very comprehensive. And so I think it has a lot of information and data in there. So I really like that you guys built this guideline with a lot of evidence. Another question I want to point out, which was brought up earlier, and I'll read it verbatim, that says, given the UN is noting that breastfeeding is a human right, do hospitals have the legal authority to refuse to allow a parent to breastfeed if they prefer to? Do you want to comment a little bit on that? Maybe and maybe give a clinical example in the context of cannabis that might be helpful too, maybe. You want.
That's a really good question. And cannabis is super tricky because it's legal in some places and not in others, right? And yeah, I mean, in some ways it gets back to this question of sort of the trust in the parent. And you can tell someone not to breastfeed and then they're discharged with the baby 2 days later and they go home and they breastfeed, especially if they've been kind of keeping up stimulating milk production. And so, we can't dictate everything that a parent is going to do if they have custody of the infant. I had a resident recently ask me about, like, well, the parent is prescribed this much oxycodone, and that's up to, maybe over 40 milligrams a day, which is kind of our cutoff for oxycodone, in terms of exposure in the breast milk. And I was like, well, then you just have to have that. He was like, should we tell them not to breastfeed? I was like, no, you have a conversation with the parent, just like you would tell them, don't, drink a lot of alcohol while you're breastfeeding. Like if you have this scenario come up where your pain requires this, which is very important to treat your pain, then hold off in breastfeeding, right? For some short amount of time. But people are capable of that. In terms of being told not to breastfeed. I think that's why we have to be careful about our language. We use all this language like they're eligible to breastfeed, they're not eligible to breastfeed. And it's part of the monitoring and policing that happens for people with addiction that all of you know so much more about than I do. But it's just astounding when I talk to parents how monitored they are, how fearful they are of me missing one appointment because that could, look bad on their record, right? I could miss appointments up the wazoo with my child and no one's going to question me about it. So, and just assume she's a busy doctor, like, and so there's a huge double standard here. And I think it comes back to, I like to quote, uh, Sharon Odsfeld Jones, who talks about having a unconditional positive regard, and starting with that, and then taking pause when things seem to be not going well for that diet, right? But these are the hard ethical questions that I think that we need to consider, and hospitals should maybe be reconsidering the language they use and having real shared decision making around this.
I love that. So I'm gonna now close on those words. I'm gonna say a big thank you, Kate, for coming and presenting to us. Like I mentioned in the chat, we will be sending out the recording of this on the WAG listserv, and it'll be posted on ASIM Member Connect. I put the link to my lab's YouTube channel too. If you're not on either of those, I also put in the chat the email you can send if you want to get on the listserv, so you can make sure you get all these invites and information. So please feel free to connect with us. This was great information. Again, I'll just plug, if you want to click on the link real quick, download the guidelines, print it out, just put it in your bag if you have some free time one day. I remember I read it one day when I was waiting for my children at a trampoline park. Ironically, I was there for a while. It took me a while to read it. And so therefore I had some time to kill. But it was in my bag, so I got read. So just going to promote that because I really like how evidence-based this guideline was, and it gave copious amount of references with all the data that we do have available, even though there are a lot of research gaps that still remained. So thank you again, Kate, and we will see everyone next month at our next journal club. Thank you.
Thanks. Feel free to reach out. Bye bye.